Welcome back after having lunch. It's great to see that people are still surviving after a very long day in the morning. Still, we have some more material to go through, so much exciting stuff to talk about, and we got also very exciting and inspiring speakers this afternoon. First of all, I would just like to introduce our moderators for the next session. Friends and moderators, Dr. Abdullah Al-Hawash, consultant neonatologist and head of section in King Fahd Medical City, Riyadh. Dr. Abdullah completed his fellowship in McMaster and then did neurocritical care in Toronto. Next is my dear friend, Dr. Abdullah Al-Bur'i, consultant neonatologist and unit head at King Fahd University Hospital. Did also training in Australia and has training in neonatal transport. I'll leave the floor to you. Thank you.
Thank you so much, Dr. Talal. Thank you so much. We'll start our afternoon sessions. It's a great honor to welcome Professor Joseph Noe. He's a distinguished leader in neonatal gastroenterology and nutrition. Professor Noe completed his medical training at University of Wisconsin, followed by pediatric at Johns Hopkins and neonatology at Stanford University. He had been with the University of Florida since 1984, where he continues his groundbreaking research in developmental gastroenterology and nutrition. He's an author for more than 350 scientific publications. Professor Noe is internationally recognized for his pioneering work in multi-omics and artificial intelligence application in neonatal care. Last year, he received the prestigious American Academy of Pediatric Fanroff Neonatal Education Award, a recognition for his outstanding contributions to neonatal education and research worldwide. Today, he will present Dogmas versus Scientific Basis for Nutrition in Preterm Infant, and later in the program, he also will deliver a lecture on artificial intelligence and multi-omics for enhanced diagnostic in preterm infant. The floor is yours, Dr. Noe.
Thank you very much for that kind invitation. It's a real honor to be here, and I want to thank the organizers for inviting me. I've been here a few times before, and I've made many good friends here, and I hope to continue to make more friends as we go on in this meeting, and also to exchange ideas. So the topic of my first lecture is Dogmas versus Scientific Basis for Nutrition in Preterm Infants. And this is my disclosure slide, but there's no conflicts of interest in this lecture. And the agenda is as follows. I'm going to talk about the importance of early initiation of enteral feedings, how fast we should initiate these feedings and advance them, what feedings should be provided, gastric residual measurements, enteral feeding while using vasoactive agents, feeding infants with congenital heart disease, enteral feeding while on therapeutic hypothermia, during transfusions, should we be using glycerin suppositories and enemas, and some guidelines, pros and cons, and then just a real touch on the future. So, dogma and tradition. Some of you probably know who this is. This is Dr. Richard Feynman. He's a very famous physicist. Works at Caltech, and he's won the Nobel Prize for physics. But in addition to being an outstanding physicist, he's made several very interesting quotations. In fact, he has a book on some of his quotations. And one of his quotations is that we must be careful not to believe things simply because we want them to be true. No one can fool you as easily as you can fool yourself. The definition of a dogma is a principle or set of principles laid down by an authority as incontrovertibly true. And a tradition is a belief, principle, or way of acting that people in a particular society or group have continued to follow for a long time. Now, I've had the opportunity to be in neonatology and pediatrics since the mid-1970s. And it's amazing that some of the practices that we developed in the late 1970s, early 1980s in neonatology, we are still doing some of these things, and there's all kinds of new ways of doing things. And so we have to maybe begin to think about this and think of new paradigms. Here's one that I know that there's a lot of heterogeneity in terms of how people feed premature babies. But in the past, these were all excuses not to put food into the gastrointestinal tract of premature babies. This is where I was back in the late 1970s, early 1980s. If a baby had low APGAR scores, if umbilical artery catheters were in place, if they were having apneas or bradycardias, if they were on mechanical ventilation, if they were getting CPAP or vasoactive drugs, we would stop enteral feedings in these babies. And we also had this idea that if we have parenteral nutrition, these babies can grow quite well on parenteral nutrition. But none of these have proven to be factual and evidence-based. But we are really concerned. We have a tremendous fear of this. This is a baby who developed necrosis of the intestine, went to surgery, and the baby died of necrosis. And if you are a neonatologist whose colleagues have told you, the reason this baby got this is because you fed this baby too early, you will always remember that, okay? That is a concern. So IV nutrition is one way that we start nutrition in many of these babies, but sometimes we really delay enteral nutrition. But why is enteral feeding important? Well, this lady is from the United Kingdom, very famous nutritionist, Dr. Elsie Widdowson. And Dr. Elsie Widdowson did some studies where she showed that the suckled pig's duodenum gains 42% of its weight in the first 24 hours after birth. If that piglet does not suckle from the mother, there is no gut growth. This is something called a trophic effect of food in the gastrointestinal tract. And we have found that this is true, not just for the suckled pig, but for humans as well. So what happens when this baby is not enterally fed? And then the next question is, how fast can enteral feedings actually be advanced? Well, the story here dates back to quite a few years. This is some work that was done by a colleague by the name of Alan Lucas from the UK. And he looked at babies at the time of birth, 6 days after birth, and then 6 days after birth without being fed, 6 days after 6 days after birth, fed and well, and 6 days after birth, fed and having RDS. So these are the hormones that were looked at: enteroglucagon, gastrin, GIP, motilin, and neurotensin. At birth, this is the levels that we're seeing. At 6 days, without being fed, what happens to these hormones? Nothing. No food in the gastrointestinal tract, no increase in the hormones. You put food in the gastrointestinal tract, what happens? Marked increase in these hormones. And these are very important hormones. For example, motilin is a hormone that causes motility of the gastrointestinal tract. So if you don't put food into the gastrointestinal tract, you don't have motility to move food through, or to move the contents of the intestinal tract through, which can be problematic. So food is a very important stimulus for these hormones. What happens to the liver if you give TPN, in other words, only parenteral nutrition without enteral feedings? This is work that was done at Baylor University and published in 2006. And what we see here is this liver and this liver. This is a liver of a piglet that was getting enteral nutrition. This is the liver of a piglet who was getting TPN for only 7 days. you can see a remarkable difference by just looking at the livers of these animals after only 7 days of either enteral feeding or TPN. If you look at the histologic picture, the H&E staining of the TPN-fed animal shows ballooning of the hepatocytes. You see fat staining and glycogen staining, all signs of damage to the liver after only 7 days of TPN. This is another interesting study. This was done in human babies, and this was published in the 1990s. And in the 1990s, it was still very common to not feed premature babies for long periods of time. And so at that time, this study was feasible. So they had 2 groups of babies with a average birth weight of 1 kilogram and gestational age of 28 weeks. One group received what was called GI priming starting from day 4 to 14, and the other group received only TPN to day 15. And the question they asked in this study is, what about permeability or leakiness of the gastrointestinal tract if you are not feeding these babies? And they used a technique called the lactulose to mannitol ratio to measure permeability. Lactulose is a sugar that goes between intestinal epithelial cells. So let's say my fingers are intestinal epithelial cells, okay? And if you have the intestinal epithelial cells spread apart, you have leakiness of the gastrointestinal tract, and you can use the lactulose as a measurement of leakiness of the gastrointestinal tract. Mannitol goes into the cells. So the lactulose to mannitol ratio gives you an idea of what the permeability or leakiness of the gastrointestinal tract is. And what did they find? Here is the TPN-only babies, and here is the GI priming. And you see that the TPN-only babies had a much higher intestinal permeability or leakiness of the gastrointestinal tract. So why would that be important? Well, if you have a leakiness of the gastrointestinal tract, microbes, various antigens can pass through, and then they can stimulate a highly immunoreactive subepithelium. And that highly immunoreactive subepithelium can cause an inflammatory response. And that inflammatory response is not just localized to the gastrointestinal tract. It is localized, it spreads to every organ system of the body. This is something called a systemic inflammatory response. So lack of enteral feeding, leakiness of the gastrointestinal tract can lead to increased propensity for a systemic inflammatory response. And here's some interesting data. This is a retrospective observational study that was done at Harvard by a colleague, Dr. Konakova was the first author, but Cami Martin was the senior author of this paper. And what they did was they looked at babies who are fed early versus babies who are fed late. Early feeding was starting feeding less than 4 days. Late feeding was after 4 days. And they looked at various outcomes: necrotizing enterocolitis, ROP, chronic lung disease, PVL, IVH, and all these comorbidities together. If we look in this column over here, this is the late-fed babies. We see that all of these comorbidities are considerably higher than in the early-fed group, supporting this concept of systemic inflammatory response. And the other thing that they found in this study was that the late-fed group at 2 weeks after birth also had higher levels of IL-8, which is a very important leukocyte chemoattractant, which is involved in an inflammatory response, systemic inflammatory response. Now, what happens to the microbes in the gastrointestinal tract if you provide TPN versus enteral feeding? This is a study that looked at using what's called microbiome analysis. And I'll talk a little bit more about that in my next lecture. But this is by using DNA-based technologies to evaluate the types of microbes in the gastrointestinal tract. And here we see, this light is not working, here we see the TPN, the fed babies on the left and the control babies on the right, and the colors represent different phyla of bacteria. The control babies, one of the things that you see is week 1 to week 4, you see a decrease in the green. These are proteobacteria. And you see an increase in the blue, which is the firmicutes, okay? So the green, the proteobacteria, have a lot of LPS, lipopolysaccharide, in their cell walls. And the blues are the ones that are largely the gram-positive microbes that produce short-chain fatty acids in the gastrointestinal tract. Butyrate is one of these short-chain fatty acids. Butyrate is the most important fuel for the cells lining the colon. Butyrate is also important in maintaining junctional integrity between epithelial cells. Low butyrate levels, open junctions. Normal butyrate levels, you have closed junctions. So what are we seeing? In the TPN babies, we see more of the bad guys compared to the good guys, compared to the controls. So TPN leads to an overabundance of the proteobacteria compared to the firmicutes, okay? And this is a potentially bad thing. So here's just a summary of what I was just saying. If you provide PN and lack of enteral feeding, you get mucosal atrophy, you have a lack of trophic hormones, you have increased parenteral nutrition-associated sepsis, you have more of a propensity for systemic inflammatory response syndrome. These are all problems that we see with not putting food into the gastrointestinal tract. So how do we go about putting food into the gastrointestinal tract? Well, in the past, we've had these concerns that we can't feed these babies very quickly. This is a trial that was done in the UK, and the title of this was Controlled Trial of 2 Incremental Milk Feeding Rates in Preterm Infants, sometimes referred to as the SIFT trial. And what they did in this study was they compared an advancement of 18 milligrams per kilo per day versus 30 milligrams per kilo per day, okay? What they found was that there was no difference between the groups in terms of necrotizing enterocolitis, sepsis, or adverse outcomes. The groups that were fed more rapidly actually had less time on TPN, which would be expected, okay? So there seemed to be some slight advantages to going a little bit faster. However, I have to warn you about this because one size does not fit all, and you will hear this several times over. One size does not fit all. This lady, Professor Sushma Nangia, is a professor of pediatrics and neonatology in New Delhi. And I first heard her talking about this topic several years ago. And one of the things she was doing was feeding babies enterally, premature babies enterally, faster than what most people would feed them. So if you look to your, I wish that this was working better. If you look at the table at the left here, you see early total enteral feeding versus conventional feeding. Conventional feeding was advancing at 20 milliliters per kilo per day. And the early total enteral feeding was advancing much faster, so that usually by around 5 days, 6 days, and that's what you see here on the right side of the slide, you see that the early total enteral feeding, those babies received full enteral feedings by 6 days, whereas the conventional feeding did not receive it until 10 days. And she found that this was actually beneficial in many ways. Secondary outcomes showed some benefits, including getting these babies off of the IV much faster. Using this technique, many babies did not even require an IV. Did not even require an IV if they didn't have hypoglycemia, because they were able to get the feedings up to full feeding so quickly. Well, I was initially skeptical when I saw these studies. And you have to remember that these were babies with an average gestational age of 31 weeks, 31, 32 weeks gestation. Okay, so these were bigger premature babies. But I was initially skeptical because I thought that in India, babies tend to be more small for gestational age, more IUGR than we would have in the United States and many other places. But then some others repeated these studies. And this is one of the couple of studies now from the United States done by Dr. Ariel Salas. And the title of this was Early and Exclusive Enteral Nutrition in Infants Born Very Preterm. And they found the same thing in the U.S. population, that they could get these babies up to full enteral feedings if they were more like 31, 32 weeks gestation without even starting total parenteral nutrition. And many of these babies didn't even need an IV. So very interesting. So that's one end of the spectrum. What about the other end of the spectrum? What about babies like this, our little 25, 26 weekers that we put on CPAP or NIPPV? We see this kind of a thing. We see CPAP bellies. We see this distension of the abdomen. And if you see this, you may be a little bit reluctant to increase these babies at 30 milliliters per kilo per day of feeding. I would not feed a baby like this that rapidly. I would go much more slowly. Okay, that's the other end of the spectrum. So even though the SIFT study showed that it is okay to feed these babies more rapidly than we originally thought, that's a Gaussian distribution that aims toward the average, but we still have to use clinical judgment to be able to appropriately provide more precision nutrition to these infants. Okay, so here's this little premature baby, and let's assume you're on call at 2 o'clock in the morning, and the nurse calls you and says that this baby who is being fed 2 milliliters of breast milk every 3 hours is having 4 cc's yellow gastric residuals. What do you do? Okay, now let's think about gastric residuals. Are any of you still measuring gastric residuals? No more. Thank you. That's wonderful. What about 10 years ago? How many of you were measuring gastric residuals 10 years ago? Everybody. Okay. So what happens when the nurses measure gastric residuals? Okay. So if you're feeding a baby 8 times a day and the nurse measures the gastric residual before each feeding, that nurse pulls back. And if there's some food there that might look, some material there that might look a little bit yellowish, maybe a little bit green, she throws that away. Guess what? That baby has been working very hard to secrete acid and to secrete pepsin to try to digest that. And the nurse throws that away. That's not necessarily the best thing to do, right? And then each time the nurse pulls on that tube, she could be doing a little biopsy of the intestine as well. Well, so from a theoretical standpoint, there could be some problems with checking gastric residuals, okay? Well, here's a little history. The guy on the top here, Dr. Roberto Murgas, was a fellow in our neonatal intensive care unit. And about 10 years ago, he came to me in my office and said, I'm sick of measuring these gastric residuals. I don't know what to do with them. And there's no literature that really guides me in any sensible way. Can we set up a study where we do no gastric residuals versus doing gastric residuals? I said, the nursing staff will never let us do this. because this is dogma. This is how we've always done things in neonatal intensive care. But then the lady here at the bottom, Dr. Leslie Parker, she is a professor in the College of Nursing and also is a neonatal nurse practitioner. She was able to help us talk to our nursing staff and to convince them that we should do a study. So we started out with a small pilot study that Dr. Murgas did with about 40 babies and found that there was no difference in necrotizing enterocolitis or any kind of adverse outcomes by not doing gastric residuals. And it also provided some confidence for Dr. Parker to submit a National Institutes of Health grant application for a 5-year grant to study doing no gastric residuals versus routine gastric residuals. And that's what was done. And the conclusion of this study was seen here. The results of this trial suggest that evaluating gastric residuals is unnecessary and may decrease the delivery of enteral nutrition to extremely low preterm infants. Limiting gastric residual evaluation to infants with symptoms of gastrointestinal dysfunction may increase enteral nutrition delivery in this vulnerable population, and this can be translated into evidence-based practice in the care of very low birth weight infants. We stopped routinely doing gastric residuals after this. This was published in JAMA Pediatrics, and I think that this actually changed practice because this guy up here asked the question, should we really be doing this? Can we challenge this dogma? Here's another case, 27-week preterm infant being treated with indomethacin for patent ductus arteriosus. And I'm going to ask the question here. Is it appropriate, is it most appropriate to, number one, stop all enteral feedings? Would any of you stop all enteral feeding? Continue enteral feedings. Okay. Provide only hydrolyzed formula. Yeah. Obtain an abdominal radiograph as a baseline in case you want to rule out neck. No, it doesn't make sense. So 2 is probably the correct answer. But 10 years ago, when we were using a lot of indomethacin, this was common practice to stop feedings on babies who were getting indomethacin. Well, here's an interesting finding. This is a study done in animals, in piglets, also done at Baylor University, and they looked at superior mesenteric artery blood flow during enteral feeding and during TPN. So at the left part of this, you see this high level of superior mesenteric artery blood flow. That's during enteral feeding. You stop the enteral feeding, and what happens? Superior mesenteric artery blood flow decreases. So what was the rationale for stopping enteral feedings with indomethacin? The concern was that you would decrease superior mesenteric artery blood flow to the gastrointestinal tract with indomethacin. But if you take this and think about this, if you decrease superior mesenteric artery blood flow with indomethacin and you stop the feedings, you will decrease the superior mesenteric artery blood flow even more and make it worse. And this is actually a clinical study that was done at University of California, San Francisco by Dr. Ron Kleiman and colleagues. And the title of this was Enteral Feeding During Indomethacin and Ibuprofen Treatment of a Patent Ductus Arteriosus. And the main results were that infants randomized to feeding arm required fewer days to reach the study's feeding volume end, 120 milliliters per kilo per day, and that would make a lot of sense because you are feeding these babies. But there were also no differences between the two groups in incidence of infection, necrotizing enterocolitis, spontaneous intestinal perforation, or other neonatal morbidities. So with this, I think it makes sense not to withhold feedings during indomethacin treatment. And I think we can extrapolate this to some other drugs as well. For example, some of the vasoactive agents that we use, epinephrine, norepinephrine. Here's another quiz. Can we safely feed infants with critical congenital heart disease? Let's say that you have a baby with a hypoplastic left ventricle, and this baby has just been diagnosed. And the baby has been started on prostaglandin. Would you feel comfortable feeding this baby using the gastrointestinal tract? I see some hands going up. Okay. Very interesting. There's many people who absolutely will not feed a baby right away with interrupted aortic arch, hypoplastic left ventricle. Why? Because they are afraid that those babies are not going to send blood to their gastrointestinal tract. And those babies do have higher incidence of ischemic bowel disease, okay? But feeding does not seem to play a role here, and I'll show you some data that supports this. So here's just some of the rationale. Congenital heart disease represents an increased risk for neck, and I put neck here in quotations because this is not the same, quote, neck that we see in our premature babies. This is ischemic bowel disease, lack of blood flow that causes this. Cardiogenic ischemia. There's diastolic steal. There's decreased mesenteric oxygenation, and there's also PGE effects that could affect the bowel. So there's wide variations in practice. So here's one study that was done in Scandinavia, and the title of this was Low Risk of Necrotizing Enterocolitis in Enterally Fed Neonates with Critical Heart Disease, and this was an observational study. This is very difficult to do, doing a prospective randomized trial, so I think we have to rely on some of these observational studies. But this study showed no increase in adverse outcomes if they fed these babies using the gastrointestinal tract. And here's another one. And title of this is Feeding Neonates and Infants Prior to Surgery for Congenital Heart Defects, Systematic Review and Meta-Analyses. And the conclusion of this study was very similar. No association between neck and preoperative feeding status in neonates awaiting cardiac surgery. So I think we should begin to feel a little bit more comfortable in putting food into the gastrointestinal tract of these babies with congenital heart disease, even hypoplastic left ventricle, coarctation of the aorta, and interrupted aortic arch. What about during blood transfusions? I see one thumb going up. Do you feed babies during blood transfusions? Okay, good. Well, what happened a few years ago? This study came out in 2012, Transfusion-Associated Necrotizing Enterocolitis, Evidence and Uncertainty. Well, there were a few studies that showed that with transfusions, the rate of necrotizing enterocolitis was significantly increased, and it was thought that this was causal, that the transfusions actually caused the necrotizing enterocolitis. And so with this, and with this fear of necrotizing enterocolitis, if you are feeding babies, many neonatologists stopped feeding babies during transfusions, before, during, and after transfusions. Well, this is some work that was done a few years later. One of these studies came from our group at University of Florida. The other group came from Stanford, Dr. Bennett's group. And the title of these is very interesting. Packed red cell transfusion is not associated with increased risk of necrotizing enterocolitis in premature infants, and red blood cell transfusions is not associated with necrotizing enterocolitis. This actually began to refute the original 2012 information that suggests that it was caused by these transfusions. So that's one point to remember, is that it may not be causal. And then we had Ravi Patel's studies that showed that red blood cell transfusion, this was a large study, in a given week was not significantly related to the rate of neck. More likely, these neck incidents were associated more with the anemic component, the babies being anemic rather than the transfusion itself. So feeding during transfusion and the risk of necrotizing enterocolitis, there have been now a few studies looking at this more systematically. This happens to be one small study, and the conclusion of this study was no significant decrease was noted in the rates of transfusion-associated GI problems after feeds were withheld during transfusion. Further studies are warranted to explore the relationship between feeds during transfusion and NEC, but I think for the most part, the evidence that we have with a lot of experience now with feeding these babies is really supporting that we can feed these babies who are getting transfusions. Human donor milk as a panacea. Should we question the dogma? I know here in Saudi Arabia we don't have human milk banks per se, but this is something that is very common now across much of the world. I know that Brazil, India, very large countries have now developed human milk banks. And I think that we need to actually take a step back and think about this donor milk and how efficacious it actually is. And there have been some studies that actually are telling us that maybe this is not as much of a panacea as we thought it was at one time. Here is some guidelines from the U.S. American Academy of Pediatrics in 2012. If mother's own milk is unavailable despite significant lactation support, pasteurized donor milk should be used. Quality control of pasteurized donor milk is important and should be monitored. Shortly after this came out, this was considered to be the rule that we had to start using either mother's own milk or banked donor milk. This is a more recent AAP statement. Pasteurized donor milk is recommended for very low birth weight infants when the mother's milk is not available or as a supplement to the mother's milk. And we need public policy to expand access to pasteurize human donor milk. Should we question these assertions? This is our, elite body telling us that we should really be using this and that we need public policy to expand this. And I think that this is why some countries have really started to develop these donor milk banks. Well, let's talk a little bit about the evidence. This is a study that was done at the University of Florida by the same person that I showed you before, Dr. Leslie Parker. She did a study looking at what happened over a 3-year period after 2012 to the use of baby's own mother's milk in our neonatal ICU. So donor milk became available. We were being told to use donor milk. And the question was, what does that do to the use of the baby's own mother's milk? And I know there's a lot of fine print here, but I'm just going to tell you what happened. Baby's own mother's milk use decreased after that, okay? The concept was that donor milk is available. It's good stuff. We should be using that. So mothers, nursing staff, the neonatologists felt, okay, it's okay just to use donor milk, and there was not a big push to use the baby's own mother's milk. So this actually is potentially problematic. The protein requirement of the fetus is about 3.5 to 4 grams per kilo per day. Protein content of donor milk is usually less than 0.6 to 1.4 grams per 100 milliliter. So if you do the math, an extremely low birth weight infant, if you want to match the amount of protein that baby would be getting in utero, is 330 milliliters per kilogram per day of term donor milk. That's a lot of fluid. So one of the things we have to do is then supplement this donor milk, this bank donor milk, with some form of supplement, cow's milk supplement, for example. But even with supplementation, we still have some problems with donor milk. This is a Meta-Cochrane review that looked at weight, length, and head circumference of babies getting donor milk versus formula. And we see that the growth with weight, length, and head circumference actually favored formula over the fortified donor milk. What are we seeing in this picture? See a baby with a broken humerus, okay? This is all too common in our neonatal intensive care units, and one of the reasons is because these babies, it's very difficult to get enough calcium and phosphorus into these babies. So if you look at the amount that's required per day, you need 184 milligrams per kilo per day of phosphorus and 126. Human milk contains 45 and 21. That's a lot less than what is required. So then you can either use formula, either term formula or preterm formula. Term formula is not good enough. So you have to use either a preterm formula or a fortified, a form of fortification to get that amount of calcium and phosphorus into the baby. So calcium and phosphorus, you need to fortify that donor milk, or you even need to fortify baby's own mother's milk to be able to get that kind of calcium and phosphorus into our preterm babies. Now here's a very important point. The macronutrients, the type of macronutrient, even though the quantity may be low, but the type of macronutrient in human milk, the carbohydrate, the lipid, the protein, they're all good types of carbohydrate. But there's one thing that's missing when you look at donor milk, when you look at pasteurized donor milk. And these are the bioactive components. And this is work that was done by a colleague from Perth, Australia. And after pasteurization, 62.5 degrees centigrade for 1/2 hour, what do we find? We look at some of these factors, bioactive components. Alkaline phosphatase, bile salt stimulated lipase, two very important enzymes in mother's milk. They're gone. Pasteurization kills them. IgA, IgM, IgG, decreased markedly or abolished. The cellular component, they kill the cells. The microbes, there are microbes in human milk that are thought to be potentially beneficial and personalized for each baby. Pasteurization gets rid of that too. So what you are actually doing is really, really getting rid of many of the bioactive components with the pasteurization process. There's also human milk personalization and dynamic interactions. If the baby is feeding its own mother and has close contact with that baby, skin to skin, what happens is that if the baby is colonized by certain microbes that are very common to get colonized by in a neonatal intensive care unit, that baby's immune system may not be able to respond to those microbes. But with close contact with the mother, those microbes get into the mother's system, and the intramammary system begins to make antibodies, begins to make immune cells. Those immune cells and antibodies get into the milk and get into the baby by suckling from the mother's breast. And so you can actually see changes in the types of antibodies and types of cells in the mother's breast milk while a baby is recovering from an infection. Fascinating, dynamic response that we sometimes forget about, but we should not. So skin-to-skin care, the baby's own mother's milk, very important because of this intramammary system. This is a study that was done in Canada by Debbie O'Connor and colleagues, and this was a domino study. It was a prospective randomized trial of donor milk versus preterm formula. The primary outcome is seen here, and I quote, among very low birth weight infants, use of supplemented donor milk compared with formula did not improve neurodevelopment at 18 months corrected age. If donor milk is used in settings with high provision of mother's milk, this outcome should not be considered a treatment goal. And secondary outcomes, donor milk-fed babies compared to formula-fed babies showed statistically significant and highly clinically relevant 10.6 lower language and motor development receiving the pasteurized donor milk supplements compared to formula. However, fewer infants in the donor milk group had necrotizing enterocolitis stage 2 or greater than the formula group. But there was no evidence of a difference in surgical NEC. Now, I could talk for a couple of hours about this, but I can tell you that stage 2 necrotizing enterocolitis, the radiologic diagnosis of necrotizing enterocolitis, is a mess. When you ask different radiologists to look at the same x-ray, there's something called a kappa value. If they all agree, the kappa value is 1. A recent study that I've been involved with 2,200 babies showed a kappa value of 0.38. So if you're going to use radiologic necrotizing enterocolitis as a outcome measure, I think that that's just a total mess, and I would not recommend doing that, not anymore. So these studies that we have of donor milk decreasing necrotizing enterocolitis should be taken with some skepticism. Now here's some other studies. I'm sure many of you have heard of Prolacta. Okay, this is a human milk fortifier, and this is now commonly used in many babies. And the story in our neonatal intensive care unit was we have two groups, support groups. One is a nutrition support group, the other is a tiny baby support group. 5 years ago, we looked at the evidence in the nutrition support group, and we did not think that there was enough evidence to begin using Prolacta. But the tiny baby support group felt that it was that we should probably start using it. So tiny baby support group won that argument, and we started using it in our neonatal ICU at the University of Florida. Saw no real difference in the development of NEC. And then these two studies came out. One study from Canada, Debbie O'Connor's study, and the other study was from Jensen. And both of these studies showed no improvement in morbidity, mortality, or feeding tolerance with the human milk fortifier. We took that very seriously, and we stopped using the Prolacta in our neonatal ICU about 1.5 years ago, and it is saving us $500,000 a year not using Prolacta. Association of enteral feed type with neurodevelopment and neonatal outcomes in infants born preterm. This is another interesting study that showed that donor milk in place of mother's milk was associated with poorer cognitive and language development. Again, this was a retrospective, not a prospective randomized trial. And finally, this is just a quote from my colleague Nina Modi from UK. Milk from a baby's own mother is not the same as that from other women. And feeding breast milk is not the same as breastfeeding. These points are of crucial importance, and they're obscured by the term human milk. Okay? So I think that this is still an area that requires further analysis and certainly further studies, but I know that what I just told you is very unpopular in many places, but this is the evidence that we have, and I think that we should begin to look at this evidence very carefully before we think that this dogma is something that should be perpetuated. So human milk is not a panacea. And just a repeat of the work that I just went through. So here's another feeding dogma. What about during hypothermia for HIE? Do you feed your babies while they're on hypothermia during? I see some hand. I see one hand going up. Okay, two hands. I see. Oh, good. Okay. Well, this has been dogma in the past. There's been concern, and this is theoretical concern, that because these babies are getting this low temperature exposure, that you may actually be causing injury to the gastrointestinal tract by feeding them. Well, very interestingly, some people started to look at the data from Scandinavia and from UK. In Scandinavia, they were feeding these babies. In UK, they were not feeding these babies, and the results in the two countries were the same. So in our neonatal ICU, we started to look at this. We had some babies who were being enterally fed, some babies who were not, depending on the neonatologist. When I was on, I would feed these babies. When other neonatologists were on, they would not feed the babies. But we looked at some of the data, and we saw that at the bottom here, the graph that you see, the day of life upon which enteral feeding was initiated was different between the two groups. And then the full oral feeds were started, and the time of parenteral nutrition was different. And the length of hospital stay actually differed between the groups of babies who were enterally fed versus not enterally fed. One interesting finding that we saw, we looked at some of the pro-inflammatory mediators in these babies, and one pro-inflammatory mediator was IL-12P70. And at 24 hours and at 96 hours, this pro-inflammatory mediator was higher in those babies who were not being enterally fed. So the enteral feeding actually decreased the level of this pro-inflammatory mediator. I don't know what that necessarily means for brain development or anything else, but it blunted the inflammatory response, which we do want to see in most of our babies. This is something that then led to some other studies, and here's a meta-analysis. And the conclusion of this meta-analysis was, in late preterm and term infants with HIE, enteral feedings appear safe and feasible during the cooling phase of therapeutic hypothermia. What about evacuating the rectum and colon with suppositories or enemas? Does this improve feeding tolerance and decrease NEC? Well, there's several studies that have been done to look at this, and this is a meta-analysis. And some of the individual studies that have looked at this are very interesting. One of the studies actually shows a slight, not significant, increase in NEC in those babies who get routine glycerin suppositories and enemas. But this meta-analysis showed that glycerin suppositories provide no additional benefits to preterm infants. Now, this is also very interesting. I just came back from talking to some of my colleagues in Japan, and when they take care of their little 22 to 24 week preterm babies, they give them enemas 2-3 times a day at the very least, okay? But there's no evidence to back that up. But this is something that they just do, and I certainly question that, and I think that there's going to be some more discussion in Japan about that particular procedure. But the studies that we have, the answer to this question, the information that we have so far is no. Routine enemas, routine glycerin suppositories are not helpful. That is not to say that we should never give them, okay? There are times when I think it's very reasonable to give them, but routine is the key word. So what about the future? And I'll talk about this a little bit more in my next lecture, but here we see a fetus in utero. This fetus is getting precision nutrition from the mother. Certainly what the mother eats also a lot of things go to this baby, but this baby is getting precision nutrition based on all these different dynamic activities that go on in the mother and in the placenta. What about this baby? This baby is also getting precision nutrition, as I mentioned before, with the intramammary system. What about this baby? Is this baby getting precision nutrition? No, we've got a long ways to go. And in my next lecture, I'll talk a little bit about that. Thank you for your attention. This is just the summary.
Thank you so much, Dr. Joseph, for a very informative talk. We will leave the questions to the end of the session. Now, Dr. Abdullah.
Okay. Our next speaker is Dr. Ibrahim Al-Hifdi. Dr. Ibrahim is the president of this wonderful, well-organized conference. As well, he's the president of the Saudi Neonatology Society. Dr. Al-Hifdi formerly was a neonatologist in Riyadh Military Hospital, Tabuk, and Southern Region Armed Force Hospital. And at the moment, he's the chief neonatologist and the medical director in Saudi German Hospital in Asir. Today, we're going to have a wonderful talk with him about the impact of feeding protocols and microbiomes in necrotizing enterocolitis. The floor for you, Dr. Hifdi.
Thank you very much, Dr. Abdullah, and Chairman, colleagues, ladies and gentlemen, good afternoon. Thank you for attending this lecture, and I'm very pleased to see a good number of attendees for this talk. Talking after an international pioneer in GI or neonatology related to the GI conditions is a little bit difficult. I'll try my best to go a little bit basic and talk about the impact of three important factors in the or interventions in the prevention of necrotizing enterocolitis. Maternal feeding protocols, in which Professor Neo has gave very good details about that. Maternal milk strategies, and finally microbiome intervention on necrotizing enterocolitis in premature babies. I have no conflict of interest in this issue, but I'm very pleased to inform you that the Saudi Human Microbiome Society has been approved under the umbrella of Al Faisal University, and we will be, inshallah, soon starting our work on it, and everybody is welcome to join as soon as we advertise it. So the contents of my talk will be a simplified introduction to pathophysiology of NIC and preterm infants, the different feeding protocols effect on NIC prevention, certain maternal milk strategies, microbiome interventions, and most importantly, the combined approaches of these three interventions plus quality improvement initiatives in NIC prevention. Here's a simplified diagram of the status or the epithelium and the lumen and the lamina propria in the gut. I'm sure you are all aware of it. The left side is the small intestine and the right side is the large intestine. You can see the major differences in the layers, different layers. It's all a single epithelial layer in both large and small intestine. There is a major differences in the components. If you can see easily that the small intestine mucus layer covering the intestinal epithelium is thinner and interrupted because there is a lot of absorption still taking place in the small intestine, while the large intestine, there are two layers of mucus which separate the microbiome, or the commensal, which we used to call. It's actually separating the microbiome from direct contact with the intestinal cells. Another important issue to look at or to notice here is that just below the endothelial cells or the enterocytes, there are 70% of the human lymphatic system is in the intestine. So it forms a major part of the immune priming and immunity development from the first day of life, and probably even before that. Here is another schematic representation of a normal in the left-hand side, normal intestinal crypt, and the affected neck results in the right-hand side or right side of the picture. And as we know that necrotizing enterocolitis is a combination of risk factors leading to it, immature immune system, intestinal barrier deficiency, different types of microbiome or microbial dysbiosis, intestinal ischemia, and the reperfusion. All these cause a tissue injury and leading to intestinal necrosis. The incidence of necrotizing enterocolitis is variable from country to country, and even in the same country from center to center. And the average incidence ranges from 3% to 12% globally among very low birth weight infants, highlighting the geographic disparities. Mortality rate can reach up to 30% in severe cases of NEC, indicating the urgent need for effective preventive strategies. My talk, I will be going over the following issues or the following important preventive measures. I have also done a systematic review and meta-analysis of some of the studies which have been published in this field. I will not quote my study as a final one because it's still under revision. The aim of the systematic review I did was to assess the effectiveness of 4 interventions: feeding protocol, maternal milk strategies, microbiome interventions, and quality improvement initiatives. And the evidence was synthesized from 43 studies, randomized controlled trials, meta-analysis, and some cohort studies. Feeding protocols have been highlighted very well by Professor New. I will just highlight 3 or 4 studies in this field. The feeding protocols that regulate the timing and volume of enteral feeds play a crucial role in preventing NEC. This is very well established. But which protocol is more effective or better than the other protocols? Most of the protocols have a reasonable effect on the prevention of NEC. And I will go over 3 studies which looked into details of these protocols. The first one was the slow advancement protocol, which have shown the reduction of NEC from 16.2 to 1.1. That was published in 2017. The summary of the study is that it's still probably following the very slow type of feeding. The babies were stratified according to the birth weight for less than 750 and 750 to 1,000 grams. They were keeping them in PO for 14 days for the smaller one, and MPO for 7 days in the other group. I think very few of us are still following this, but overall, they reach full feeds of 100 ml per kg per day in the smaller infants that took them about 50 days, while the full feeds in the larger babies of 150 mils per kg per day took them a month. But still they have shown a significant reduction in incidence of NIC. The other very interesting study used two types, or looking at two different protocols of feeding, minimal versus advanced volumes. The minimal volumes is 20 mils per kg per day all through, while the advancing feeding was increased daily by 20 mils per kg per day. The study was stopped at interim analysis because there were about 7 babies died in the fast advancement group, while only one baby in the routine or the slow advancement protocol developed nucleotizing enterocolitis. The standardized feeding protocols seems to be actually probably the best, and most of us are following this type of protocol where there is in the small or very low birth weight babies, maybe though they start feeding from first day unless there is a concern, and initiate the trophic feeding of 10 to 20 mils per kg per day, and preferably mother's own milk, and go as their usual routine, but it's a fixed protocol where it is followed in most of the babies. And there is significant evidence that this protocol standardized, if followed and standardized in between all the consultants and in different units, probably it is one of the most so far. From the studies I have looked at, this is the meta-analysis and feeding protocols. On the left-hand side from the one, you will see that most of the studies have shown a significant or preference of following a feeding protocol will probably reduce NIC. Exclusive human milk feedings, we all know that it has a protective effect, and actually several studies, one of them is this one by Cristofalo, showed reduced NIC rates to 3% as compared to 21% with formula feeding. There is definitely reduced need on days of parenteral nutrition when human milk, and particularly exclusive human milk feeding, is used. Again, going over a few studies. First one is the one just I have mentioned, the human milk exposure, even if it's only 50% or more than 50% is human milk used, it reduced the NIC odds 6-fold. Breast milk versus formula, again, there are studies which have shown that mother's own milk, mother owns milk would reduce the NIC rate to 0%, and it can clearly say that human milk is protective due to its bioactive components and immunological properties, plus a lot of other important factors in the human milk. Interestingly, fresh and frozen maternal milk, some studies have shown that they are equally effective. Enhancing milk availability by high consumption of human milk, over 50%, actually, as I said, reduced the NIC rate, and the frozen breast milk is like a study done by Sun et al. Reported a similar efficacy between fresh and frozen mother's milk in NIC prevention. And here is the first plot of some of studies, or most of the study I have looked at, which has actually again showed a significant reduction and significant effect of maternal own milk in prevention or in reducing the incidence of necrotizing enterocolitis. Last one is the microbiome intervention. Several studies, a lot of controversies still going on. More and more studies are proving its efficacy. And here's one of the example studies which was published in 2017 by Chang et al. And it says that, or they concluded that they looked at actually systematic review and meta-analysis, and they combined the trials with all probiotics using multiple strains, particularly lactobacilli, bifidobacterium, and Saccharomyces. Total of 25 trials with 7,345 infants, and they have proven that the incidence of stage 2 NIC was 3.9% in the probiotic group, whereas it was 6.3% in the placebo group. Unfortunately, they are using NIC stage, radiological stage 2, which Prof. New doesn't like that. Single strain probiotics has been studied, but it didn't show that significant effect. Symbiotics, which combines probiotics and prebiotics, have shown promise in reducing NIC rates in a recent article published in 2022. The meta-analysis again shows a significant effect of using probiotics in reducing necrotizing enterocolitis. The best way is to combine all these three modes of intervention plus using quality intervention, and this way you will get the best results. And the conclusion is that a holistic approach integrating multiple strategies yield the most significant benefits. And here's the forest plot, meta-analysis of the studies I've looked at, and again, all actually proving that combining the 3 or 4 interventions will reduce NIC significantly. The quality improvement in initiatives, I will just highlight 2 studies. First one is by Sheikh et al. Implemented a quality improvement initiative that combined mother's own milk use with standardized feeding protocols and probiotic that have resulted in reducing the NIC rate to 1.9% compared to 5.6% in the controls. The study is a little bit details, and here is the diagrammatic or the diagram they have been following in certain stages, but it's actually clearly depicted or shown stages and interventions and how you can do them. The system level changes, the best study I have found or looked at is Sheila Gephardt, which she is actually a nurse, and they have done a very good study. They did, the initiatives they used as a system level change is staff education, parent engagement, and protocol standardization are crucial for sustained improvements. Their research indicated a 0.3 odds ratio for NIC with implementing the combined interventions. Their study was scoping review guided by translating research into practice. They made a framework and stakeholders engagement, and they assessed the evidence related to human milk feeding, standardized feeding protocols, medication stewardship, and prompt recognition of necrotizing enterocolitis strategies. They did not use the probiotics in this study because they were still questioning its efficiency. They found that the implementation of these strategies, which actually concentrate or emphasize parents' engagement through early education on NIC prevention and the benefits of human milk alongside multidisciplinary collaboration involving all NICU staff and the use of audit and feedback mechanisms. Their key recommendations include that prioritizing mother's own milk or donor human milk if mother's milk is not available over formula, adopting unit-approved feeding protocols, limiting antibiotics to less than 4 days for culture-negative cases, and avoiding H2 blockers because they increase the risk of necrotizing enterocolitis and sepsis. The conclusion is that feeding protocols, maternal milk strategies, and microbiome intervention effectively reduce incidence of NIC. Combined interventions achieve rates below 2%. Quality improvement initiatives are the best, and actually more and more of these studies will be coming up, proving that it's the best way to tackle NIC and reduce its risk and incidence. The future directions in this field are still to optimize strategies for long-term outcomes, such as growth and neurodevelopmental outcome, and to close gaps in evidence related to secondary outcomes. Thank you.
Thank you, Dr. Ibrahim. We'll leave the question to the end. Now, again, we would like to welcome Prof. Joseph for his second talk about artificial intelligence and multi-omics for enhanced diagnostics in preterm infants.
So good afternoon. As you probably guessed, there were some slight differences in the last lecture and also some of the things that I'll talk about, and perhaps we could even spend some time in our discussion talking about some of these. This morning, Dr. Jabbar gave an outstanding lecture on artificial intelligence, and I think that she covered many of the areas. But I'm going to maybe augment some of the things that she said, especially in some of the areas where I've been doing some work with in our own group and also collaborating with some other societies. So the agenda here, I'll talk a little bit about the definitions and types of artificial intelligence and machine learning, and also a brief background on multi-omics and multi-omics integration and how we can mesh AI with multi-omics to improve pre, peri, and neonatal care. And then I'll introduce something called the digital twin concept for neonatal intensive care, especially when how it relates to nutrition. So this is from a paper that we wrote, some definitions and types of AI and ML, machine learning, and I think that we really went through that very nicely today, so I'm pretty much going to skip this slide here. I do want to mention that I'm going to be talking a little bit about supervised machine learning and unsupervised machine learning, and I'm going to try to emphasize some of these differences. This is a neural network. And this is sort of a more sophisticated form of machine learning. And the interesting thing about this is that there's actually learning that occurs. This is not just an algorithmic approach where you go down a certain algorithmic tree. You have a feedback into that algorithmic tree so that you have learning that occurs. And what happens is that some of these lines that you see may change with learning. When you put in a new stimulus, these lines change. And some of the mathematics that's involved here are linear algebra, matrix algebra, differential equations, just to give you some terminology and the types of math that people need to go through to really understand the basics of some of these machine learning and artificial intelligence techniques. It was also mentioned this morning about generative AI and predictive AI. Most of what I'll talk about today is the predictive AI, but generative AI is this ChatGPT-4, Perplexity, et cetera. This is where they use content creation. So for example, this picture, I asked Perplexity to give me a picture of predictive modeling, image analysis, and decision support systems. And 1 minute later, I got that picture, okay, in neonatal intensive care. So this is a form of generative AI. But predictive AI is a little bit different because we want to analyze large amounts of data from vital signs, imaging, and electronic health records to predict potential complications or predict the development of certain kinds of disease entities early so that we can potentially prevent them. Identify neurological issues through video analysis, assess the risk of retinopathy of prematurity, and predict the need for interventions like mechanical ventilation, and develop precision-based preventative strategies and therapeutics. And I'll give you some examples of these as we go along. Now, that's the AI part of this. The other part of this is the multi-omics part of this. And I'm sure you're aware of genomics. I'm sure you've heard of the microbiome. You've heard of metabolome, proteome, et cetera, okay? I just want to show you a little bit of history behind the microbiome. If any of us went to a body of water, to a river or to an ocean, and got a drop of water out of that river or the ocean and put it onto a glass slide and looked at it under the microscope, we would see a lot of bacteria teeming in that drop of water. If we took that same drop of water and put it onto a regular Petri dish with an agar plate, regular agar, very little would grow. You'd probably see some growth, but you would not get a full representation of all the types of bacteria there. You might get maybe 5% at the most, okay? And this is something called the Great Plate Count anomaly. So in order to alleviate the problems with this Great Plate Count and culture-based techniques, in the early 2000s, scientists started to look at, microbiologists started to look at the genome of microbes and using sequencing technologies for looking at the genome of microbes. And so they developed two major types of sequencing technologies. One is seen at the left of this slide called 16S RNA sequencing. 16S RNA sequencing involves looking at a 1,500 nucleobase region of microbes. And there are variable regions and there are specific regions that are constant regions. The variable regions are the ones, if you sequence them and if you put them into a database, they will give you the types of microbes that are there, the relative abundance of microbes, diversity. That can tell you a lot about the microbial community, mainly who is there, okay? But then you can do something more sophisticated and much more expensive. It's called whole genome sequencing or shotgun sequencing. And that involves taking the whole DNA, all the DNA sequences of all the microbes. And the databases that have been developed and the computer programs that have been developed for that can actually give you a better idea of not just who is there, but what these microbes are able to do. Not what they are doing, but what they are able to do, okay? So we've been able to harness this technique, and this is a paper that I published with Dr. Mohan Pami from Baylor in 2017 in Microbiome. And in the first decade and a half after the year 2000, many neonatal intensive care units started to look at the stool microbiome of babies who were controls versus babies who developed necrotizing enterocolitis. So we were able to get data, sequence data from 8 different neonatal intensive care units. And with that sequence data, we were able to develop these 2 graphs. And these 2 graphs are seen here. The controls are seen on the left, and you see these colors, the blue, the greenish color, and then the bright yellow. They all seem to be about the same, going from 24 weeks to 36 weeks gestation. But on the right, you see the babies who develop necrotizing enterocolitis. We see blue increasing, we see the green decreasing, and we see almost no bright yellow. So what does this mean? Well, the blues are the bad guys, okay? I'll call them bad guys. They're proteobacteria. Proteobacteria are largely gram-negatives, E. coli, Klebsiella, Enterobacteriaceae, that have a lot of LPS, lipopolysaccharide, in their cell wall that stimulates primarily toll-like receptor 4, and that stimulates an inflammatory response. And that's what we see increasing here. We see a decrease in the firmicutes. Those are the sort of greenish depictions here, and those decrease. Those are the gram-positive microbes, and we'll call them the good guys, okay? These gram-positive microbes make acetate, propionate, butyrate. Those are short-chain fatty acids, and they're good short-chain fatty acids. Butyrate, for example, as I mentioned in the last lecture, is the most important fuel for the colonocyte, and it also is very important in maintaining intestinal junctional integrity. So what we're seeing, very interestingly here, is in the neck babies, we see this increase in the bad guy to good guy ratio, which we don't see in the control babies. Now, this is an association. This is an association. This doesn't prove that what we saw in that slide was causing necrotizing enterocolitis. So there are some things that we can do that can give us more evidence for causality. And that's seen here on this slide. In the middle, you see these different plates, These are different layers of omics. We see the epigenome, we see the microbiome, the metabolome, proteome, and genome. If you only use one of those, you get an association. But if you put them together and integrate them in an intelligent way, then you can get mechanisms using systems biology approaches, okay? And the analogy I like to use here is seen on the very left here. This is the parable of the 6 blind men of Hindustan. Each one of these 6 blind men was asked to feel this structure that you see here. One went to the side of the structure and said, "This feels like a wall." The other one went to the back of the structure and said, "This feels like a rope." The other one went to the front of the structure and said, "This feels like a spear." They got together. They were adamant in what they felt, and they could never figure out that this was an elephant because they didn't integrate their thoughts adequately. Had they integrated their thoughts adequately, they would have figured out that this was an elephant. That's what holds for integrated multiomics and systems biology. And the systems biology can give us an idea of a mechanism that is going on in a certain type of environment. For example, in a stool sample or in a saliva sample, etc. In addition to the mechanisms, if you have large nodes, if those circles are large, they could be utilized as biomarkers, early biomarkers to detect which kind of a mechanism is going on in that particular sample. So I'll get to that a little bit more later. So in this lecture, there's some areas of emphasis that I want to go through that relate to machine learning and also to this integrated multiomics, preterm birth, respiratory distress syndrome and bronchopulmonary dysplasia, intestinal injuries such as neck, retinopathy of prematurity, and precision nutrition. I think you've seen this graph earlier this morning. And this is what's called a Sankar curve and at the top. And what is done here is that you look at age, ethnicity, trimester, and you look at various features that are happening in the first trimester, second trimester, and third trimester of pregnancy. And you see what is happening during different periods of time in terms of the features that you plug into this particular program. And that can actually help you determine the likelihood of preterm birth versus term birth. In addition, if you use the microbiome, you can plug that into that formula as well. And at the bottom, you see something called a Shapley graph. And in this Shapley graph, it tells you those microbes that are at the greatest concentration or at the greatest amount in certain babies who develop preterm birth versus babies who develop term birth, okay? So for example, Lactobacillus inners versus Lactobacillus crispatus. One is highly associated with preterm birth, the other one is highly associated with term birth. We can also use this not just for looking at preterm birth, but also the DOHAD, the developmental origins of health and disease. So not only can this provide a predictor of what happens to the baby, it might even provide a prediction of what happens in adulthood and later life in these individuals. I'm not going to get into this in a lot of detail, but it involves putting a lot of features into these programs, and I think that this is something that we still haven't fully worked out, but we are making a lot of progress in this particular area as well. Now here's a relatively simple project that was done by the Korean Neonatal Network. And in this project, they wanted to be able to predict RDS development shortly after birth. And why does this matter? Because there's widespread use of routine surfactant administration to preterm infants younger than a certain gestational age. So this is very common for us to provide surfactant without really knowing if this baby has a very high risk. And so they wanted to get a better idea of the risk. So in this Korean Neonatal Network, they evaluated 13,087 infants weighing less than 1,500 grams, and they diagnosed RDS in 10,041 of them. And 23% of these babies did not have RDS, indicating surfactant was administered unnecessarily in these 23% of the infants. So what they did was they selected some perinatal and prenatal information from the Korean Neonatal Network database and used this as input data for an AI model. And this is sort of a complicated slide, but they looked at various forms of clustering in their database, and that's what's seen at the top here. And then they were able to go through a first iteration of ranking, and then they got fancy and they started to use neural networks to go even further, and they did cross-validations, and what they came out with was seen here. This is a Shapley plot showing ranked features of importance. Gestational age, blood gas analysis, you can see, you could probably have predicted some of these just by experience, but this technique actually predicted these numerically. And then what they did was they looked at the number of features on the x-axis. You can see the number of features, but then you get sort of saturated by about 20 features. You get an improvement when you look at the first 20 features, but beyond that, you don't get an improvement in terms of accuracy. So what they did with this, they created an application, a computer application, and with this, they were able to you put information into this app, and it tells you what the risk is for the development of RDS. So that's a very kind of a rudimentary form of artificial intelligence that can help prediction. What about bronchopulmonary dysplasia? Can that be predicted at birth with a fast bedside test? Well, why is this important? We have some limitations of our traditional approaches in BPD management. Early diagnosis is not that necessarily that easy. We have a lack of definitive early symptoms, variable clinical presentations of BPD. There's a reliance on oxygen requirement as a primary diagnostic marker. Difficulty in differentiating BPD from other respiratory issues in preterm infants, and all of these can lead to delayed identification and potentially missed opportunities for intervention. So this is a Scandinavian group that did this study, and this is a multi-center study of preterm infants with gestational age of 24 to 31 weeks, and clinical data present at birth were combined with the spectral data of a gastric aspirate samples taken at birth and analyzed using artificial intelligence. So they took this gastric acid sample, peak, together with the clinical data, and they used this to design an algorithm to predict the development of BPD. Here's the diagram of what they did with this study. They didn't have many patients. They ended up having 26 babies with BPD and 35 without BPD. So they used what is called a supervised learning approach. Remember before, and you've probably heard from both of our lectures, that there's supervised and unsupervised machine learning. Well, supervised machine learning is one where you know the diagnosis. Here, they had babies who had BPD or did not have BPD according to their definitions. And this is the particular test that they used to look at the gastric aspirate sample. They measured the peak, and the peak was the measure that they used to add to the clinical features. And the outcome was that 26 of the 61 included infants developed BPD. The spectral analysis of the gastric aspirate identified identified the most important wave numbers for classification and surfactant treatment. The birth weight and gestational age were the most important predictive clinical data, but by combining that clinical data with the spectral data, they were able to get a sensitivity of 88% and specificity of 91%. And so they thought that they had a reasonable point of care test that put together with the clinical data, they could help predict BPD. Now let's get into this, one of my favorite and maybe unfavorite conditions. This is something that I used to call a disease. Okay, in fact, I've written many review articles on this, and it usually started with necrotizing enterocolitis is a disease. Well, I don't believe it's a disease anymore. I think we could call it a condition. It's a multifactorial condition and not a specific disease. And I'll talk a little bit more about this as we go through this. But in 2011, when Dr. Alan Walker and I wrote this review article in New England Journal of Medicine, we called this picture a representative of classic necrotizing enterocolitis. Baby had distended abdomen with some periumbilical erythema. We saw some air in the liver. We saw some pneumatosis intestinalis. That baby got worse, and that baby ended up going to surgery and having an actual necrotic bowel, okay? And we called that classic necrotizing enterocolitis because in 2010, 2011, we were beginning to recognize that there were other intestinal entities that we were calling necrotizing enterocolitis. For example, spontaneous intestinal perforation. There still is no ICD-10 code or ICD-11 code for spontaneous intestinal perforation. So in our database, if a baby has a drain placed and does not have a laparotomy, what's the ICD-10 code for that baby? Necrotizing enterocolitis. So our databases are garbage, okay? But this is something that has now become a real conundrum because what we are calling necrotizing enterocolitis is not a specific disease, and I think we need to switch the entire paradigm. So these are just some of the things that we are calling necrotizing enterocolitis. I don't have the time to get into detail in with all of these, but these are just some of the things we are calling necrotizing enterocolitis. Now, one of the things we need to do is to shift our paradigm, largely because we don't have a definition for necrotizing enterocolitis. This is a paper that was written in Pediatric Research in 2020, and in this paper by Ravi Patel, they talked about 8 different definitions of necrotizing enterocolitis. If you have 8 different definitions of necrotizing enterocolitis, do you really even have a definition? No, you can't, because this is a real conundrum. And if you don't have a definition, all of the studies that we talk about when it comes to necrotizing enterocolitis are largely faulty, because you have to have a good definition of necrotizing enterocolitis, but we don't have one. So this is from a review article written by my friend Kenny Martin. Definitions of necrotizing enterocolitis. What are we defining, and is machine learning the answer? And so at the time this was written, we already had started in our own unit to start using some very rudimentary machine learning techniques to start trying to better look at this problem. One of the questions is, can we separate early on babies with spontaneous intestinal perforation from babies who actually have necrosis of the intestine by just looking at clinical features? So we used a supervised approach where we had babies who had known spontaneous intestinal perforations and babies who had known necrosis of the intestine at surgery. And we used a couple of different techniques, logistic regression and random forest techniques, to be able to determine early features and how early features differentiated those two. And here on the right part of this slide, you see the average Gini features of importance that helped us differentiate spontaneous intestinal perforation versus actual necrosis of the intestine. And using these techniques, we were able to see really good accuracy curves, accuracy greater than 0.9. Now, Alison Luer, was the first author of this paper. She was one of our trainees. She went on to another university, Ohio State University, to do additional training, and she repeated this study. And in a different setting, she got a area under the curve of 0.7. So not as good as this. And this depends then on what neonatal intensive care unit that you are working in. So this may not be specific for a particular neonatal intensive care unit, but it is an interesting technique that might help us separate features that help us with these. Then there's something called supervised machine learning. And how does supervised machine learning work? Well, let's say you have a bushel of different vegetables, and that's the raw data, and you want to separate those vegetables into onions, into cucumbers, into peppers, okay? And what supervised machine learning does, it allows that separation to occur. Well, we did this with babies in our neonatal intensive care unit who had some form of intestinal injury. But we didn't label the form of intestinal injury in this study. There was no label, but we had 200 babies with some form of intestinal injury or dysfunction, babies who were having a lot of distended abdomens, etc. And then On the x-axis, you see the number of babies. On the y-axis, you see features. And this is what's called a heat map. And from this heat map, my colleagues at Stanford were able to use hierarchical clustering to develop 5 different clusters. We are not labeling these clusters by necrotizing enterocolitis or anything like that, but one was a surgical cluster, and one was a non-surgical cluster, one was a leukocytosis cluster. So this helped us separate these babies into different forms of clusters. And that's very important, and this is a beginning that I think is going to be very helpful for us. This is a commentary that was written by other authors about our paper. And the title of that was Artificial Intelligence to Classify Acquired Intestinal Injury in Preterm Neonates, A New Perspective. And what they said in this commentary was, first, this can't be done in just one neonatal intensive care unit. This has to be done in many neonatal intensive care units. You have to do this type of clustering to see if this is something that is repeatable in a larger population. And then number 2, they said that we have to look at pathophysiologic mechanisms, and one way to do that is to use the multi-omic kinds of technologies that I talked about before. Well, we're starting to make progress in this area. I started with talking with the United States Neonatal Network, the National Institutes of Neonatal, National Institutes of Health Neonatology Group. And what they told me was, after looking at the data, that the data in the US was not granular enough. So I went to the Korean Neonatal Network and to the Canadian Neonatal Network, and both had granular enough data. And the Korean Neonatal Network has jumped on this, and we have some very interesting data. I can't, it's very preliminary, but it's very interesting, where they find clusters using unsupervised machine learning. Now they're going back using supervised approaches and going back and forth using supervised versus unsupervised approaches, and finding certain clusters where the necrotizing enterocolitis, as we classically have described it, very high in some of these clusters. So I think that this is potentially going to be a new paradigm. And then once we have these clusters, we can then begin to look at them, each cluster individually, using multi-omic integration and finding out what's actually going on mechanistically within each one of those clusters, and find biomarkers that I mentioned before that we can apply early to tell us which type of intestinal injury this is. So we may, 10 years from now, no longer even be using the term necrotizing enterocolitis. Okay? I want to make that prediction. I'm not sure if it's going to happen, but it could very well be the case. Anybody know who this is? Stevie Wonder, okay? He's blind, okay? And he developed retinopathy of prematurity as a baby. And here we have pictures of a couple of babies, and you see a baby getting an eye examination. Does that baby look like he or she is having fun? No, no. This is a brutal, brutal procedure. And we do this in almost all babies who are preterm, less than about 32 weeks gestation, okay? Well, the problem is we do this in so many of these babies, but very few of them actually have something that we end up treating, okay? So these eye examinations are invasive, they're painful, and they have known physiologic effects on the babies. And less than 10% of these infants that are screened require treatment, Avastin or laser, under the current criteria. 80% of the mydriatic treatments enters the nasolacrimal duct and has the potential for systemic absorption. And there's many feared complications, such as cardiovascular, respiratory, central nervous system, and gastrointestinal system problems. Many of these babies just don't feed very well for a day or two after their eye exam. So this is something that it would be really nice if we could eliminate a certain percentage of these. We don't have the answer yet, but we are beginning to work on this with early detection of ROP risk, and this is very important. So what we are doing in a study that is currently ongoing is we are applying unsupervised machine learning with and without neural networks, starting with the first week after birth to predict preterm infants at risk for the development of ROP to decrease the rate of routine ophthalmologic examinations. That's one of the goals. And determine prospectively whether this predictive tool can be validated and used to select those infants most likely to benefit from early nutritional or pharmacologic interventions that might decrease the risk for interventions with Avastin or laser and/or surgery. So, for example, let's say that someone wanted to do a study on these premature babies, and they wanted to do a prospective randomized controlled trial. The number of babies actually getting laser therapy or getting Avastin in certain countries is very low. In Japan, it's actually fairly high, largely because they have so many very, very preterm babies. It's about 15%. That's a good number. But if you have maybe only 5%, if you want to do a prospective randomized trial, that'll take 2,000 babies, okay? Not so easy. But if you have a risk index, if you can get rid of some of the babies who are not at very high risk, but only those that are at the highest risk, then you can actually do a much more pragmatic power analysis in these kids and have a much lower number of babies for a randomized controlled trial. And last, I want to talk a little bit about nutrition. And this is just a alleged quote by Hippocrates: "Our food should be our medicine, and our medicine should be our food." Now, in neonatology, when it comes to all kinds of neonatal measures, we've had the past, the present, and the future. In terms of nutrition, in the past, we used largely intuition-based medicine, looking at signs and symptoms, and these provide the best guess of what is best. So, for example, slow introduction of TPN and enteral feedings. The early days of TPN, we would start no TPN in the first day or two after birth. Then we would start with maybe 0.5 grams of amino acids, then 1. I think we've begun to change from that. Same thing with lipids. We've started to change into more of an evidence-based approach. Okay, that's the present. And some of that has been based on clinical trials. But these clinical trials look at the mean, and we get these guidelines based on the mean, but it doesn't provide for us really precision-based nutrition. So how do we go about doing this? We need to have prospective evaluations of individual nutritional needs that lead to improved outcomes. So here's just an example of guidelines, enteral nutrition in preterm infants in 2022. This looks at the mean, Gaussian distribution of the mean. But we don't all respond the same to the same food intake. One size does not fit all. How do we currently monitor nutrition? Well, with growth curves, right? So here's an example of a growth curve where you see growth faltering. And we respond to this growth faltering. The problem with responding to growth faltering is that a lot of damage may have already occurred. These are highly susceptible infants who, even just a week of undernutrition or malnutrition can have a major effect on their developing brain. Do we need indicators that help prevent this, or should we just stick to the old Gaussian statistics? And can we actually predict this growth faltering before it occurs? Well, we've been doing some studies on this, and when it comes to personalized nutrition, this 23-week baby preterm versus a 29-week preterm, really are very different little people in terms of their nutritional needs. And if we use these ESPGHAN guidelines for both of these babies, you're probably not going to provide their needs the way that we should. We can do better than that. So one size does not fit all. This is a paper that was published just a couple of years ago, and this was in adults. And the title was Effects of a Personalized Nutrition Program on Cardiometabolic Health, a randomized controlled trial. They had two groups. One group received the usual pyramid type of nutrition, recommendations due to the My Plate type of guidelines. The other group actually had a lot of measurements taken and then recommendations made based on the individual's blood analyses. And they found that there was really a big difference between these two in terms of triglyceride levels, hyperglycemic responses to glucose stimulus. The personalized approach really did make a difference. So I was asked to write I reviewed this paper and I was asked to write a commentary, and I commented on how cool this work was, but at the same time I said, we don't have anything like this in pediatrics, especially in neonatology, and we need to start thinking about that in the neonatal field as well. So here's an example of some work that is being done in the UK, and in the UK they have started to do clustering. Okay, and I showed you before the kind of clustering that we did for intestinal injuries. They're doing the same for these babies to look at potential for nutritional clustering, so that if you find certain clusters, that cluster might need more amino acid, or another cluster might need more certain types of lipids, DHA, et cetera, okay? So that can help lead to precision approaches. And so this is a clustering type of an approach that can be used in the future. And you see on the left here, clustering, and you can add to that clustering and augment with the multi-omic integration. And with that, you can then end up doing the systems biology, and that will then lead to a paper similar, or a research very similar to what was done in that nature biology approach, looking at precision versus guideline approach to nutrition. That's where I think we will be going in the future with this. But this cluster-based approach is not perfect. Does clustering of nuanced phenotypes and multi-omics provide individualized nutrition? No. You still have the clusters. You still have these babies in these individual clusters. That doesn't tell what we should be giving to each individual baby, and each individual baby is still different. Now, we're getting into something that is potentially very, very complex, but something called the digital twin approach. Now, I want to just give you a little history of where digital twins come from. These are 3 astronauts. And these 3 astronauts were on outer space in the early 1970s, and something was going wrong with their spaceship. They called back to Houston. They said, okay, Houston, we have a problem here. And here's Houston. And this is a bunch of computers in Houston. And they were able to do some simulations of what was going on, simulations of what was going on in space, and then they were able to send messages back to the spaceship and tell them what they needed to do to fix that. And so these astronauts were able to come back to Earth alive and safe. So this is sort of the early digital twin approach, and this is sort of a simulation type of an approach. It integrates ultra high fidelity simulation, this is something that can be done with humans and also our babies. And this is the way that I envision the digital twin application in the future. We have this AI trained model on the right of the slide. Huge amounts of data goes into this, all types of premature babies, all types of situations. Very, very large database. Then we have an individual baby with certain kinds of features. Those features get fed into the AI-trained model. And the AI-trained model comes back and says, increase the amount of amino acid or decrease the amount of lipid that you're getting. You need to increase the calcium. This is the digital twin approach of the future. We're far from it, but I think that this is something that will help us with truly individualized nutrition. So I'd like to summarize here. AI, machine learning, multi-omic integrations are some of the new technologies when augmented by our clinical judgment provide avenues for improved future neonatal care. The areas presented in this lecture are only a small part of where we are heading. These technologies will not replace good clinical judgment. And we will need to be very careful with ethical considerations as we move forward in these exciting new areas. Thank you.
Prof. Nemri is a professor in pediatric and consultant neonatologist at King Saud University Medical City. And he also serves as the vice president of the Saudi Neonatology Society. He has a major neonatal programs across the kingdom, and most notably, he was the head of neonatal ICU, he was the director of pediatric residency program, and the director of neonatology perinatal fellowship program at King Khalid University Hospital. His contribution extended beyond clinical care to research, education, and national health policy. Prof. Nemri has authored and co-authored around more than 40 peer-reviewed publications, including pioneering work on neonatal outcome, congenital anomalies, and quality improvement in ICU systems. So his talk today will be about neonatal GI emergency. So the floor with you, Prof. Nemri, and welcome.
صوتي واضح من غير كده. طيب, we need to say thanks not only for the chairman and for the speakers. We need to say thanks for the two doctors who make all this, organize all this prestigious conference. Dr. Amjad Al-Attas is the chairman of the organizing committee. Stand up so the people, they can see you, and greet him for the great effort that he had. And on my right side, Dr. Talal Al-Tamimi is the chairman committee of scientific committee who arranged for you all the speakers, including myself. شكرا جزيلا. شكرا. الشكر موصول لرئيس الجمعية عراب نيوناتولوجي تريننج في المملكة العربية السعودية دكتور إبراهيم الحفظي. شكرا جزيلا. I'm doing this to let you know that this is the people who work hard, including the board members of Saudi Neonatology. ما أبي أكثر عليكم, الوقت ضيق, بس make it just as an exercise. To talk about the neonatal GIT emergency, we had presenting many times. And I'm presenting this again. What is the remote? ما في. فنبدأ بسم الله الرحمن الرحيم. ربي اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. ولا أعتقد to close or disclose anything. It's just source of teaching and learning. And always I love this. The more you teach, the more you learn. Especially I came from this university where at the entrance you have to read اقرأ باسم ربك الذي خلق. You have to read. And after you finish and you fill your brain with a lot of knowledge and science, you come out to find yourself وما أوتيتم من العلم إلا قليلا. Avoid post-Canadian syndrome. No post-Canadian syndrome. Whatever you learn, and we learned today a lot from our international speakers, from our president, about the GIT. And more important, to talk about feeding and necrotizing enterocolitis. And when you talk about the GIT malformation, it comes to one of the highest country in congenital malformation, Saudi Arabia. And more in the literature data about the brain malformation, heart, renal, a little bit about the GIT. But how common is it? Malformation in Saudi Arabia is more common than any Arab country. the incidence is almost reaching to 1.3 per 1,000 live birth. So if we look to the literatures in the surrounding Gulf CC, almost the same, 13, 12, 15 per 10,000. Saudi Arabia, 13. Lower than that in Yemen is only 7.7 per 1,000. And when you look to the types of the GIT in the international, small GIT problems. Small GIT from the atresia to esophageal fistula. But when you look for it in Saudi Arabia, mainly is a large intestine, anorectal malformation and down. And when you look to this, you find the anorectal malformation, Hirschsprung disease, anal stenosis, and all the lower. So what is the relation? Why in Arab babies, more of lower GIT, in the Western, more of the upper GIT malformation? Any idea? Why it's more common in Saudi Arabia than the Western? And why our babies have more of lower GIT anomaly? So I looked at this question in the literatures, and I found it is related to the genetics. The same thing also in Yemen. Upper GIT is more common. So all are related to the consanguinity. Consanguinity increasing the malformation, as well as Hirschsprung disease anorectal is gene-related malformation. We know the Hirschsprung disease is a gene. In addition to the maternal obesity, maternal diabetic. This two risk factor was there in all the literatures. So why we are presenting it? Because it requires immediate suspicion, early diagnosis, and intervention. Otherwise, it will end up with very high mortality and morbidity. And when I look to the morbidities, I found this in the literature, mortality among 200-something cities or countries, including Saudi Arabia. So they classified them into high income, low income, middle income. We are high income, but they choose a 5-star hotel or 5-star hospital, King Faisal. They are high income hospital. But if you look to the periphery, you may find the same finding. I will show it to you. So what they found that they involve all these countries, and according to their classification, the high income, only United States, Canada, Japan, Australia. Wow. Saudi is the highest. Why not including? I don't know why. They put us in the middle income country. And when you look to the outcomes from the intestinal atresia to the lower GIT, more mortality in the low and middle income compared to the high income country. So our baby die more if they have a GIT anomalies compared to the Western countries. In all the aspects, from the lower and more, it is at gastrous cases, more of esophageal atresia, and that's attributed to more genetics, more other congenital anomalies. So why is that? When I ask, I found the answer in the published paper that the high-income country, they have overall mortality is 5 to 6 because of good access to the care, early diagnosis, and I will impress on the early diagnosis, and advance in ICU. Our in ICU more advanced than America. I have no problem with that. But you know what's our problems? Our problems we have in the low income, overall mortality is very high. And simply because we have poor access, especially to the pediatric surgeon, poor facilities to diagnose, and then the NICU intensive care. Maybe this is the difference. So the more important one is when you have a late diagnosis and we have very late access to the tertiary center to do the operation and the diagnosis. So that's why I'm presenting it. For the people, I will show you some cases of upper GIT or lower GIT missed cases. And misdiagnosis in the literature, 5 to 10%. In Arab and Saudi, we don't have any data, but I think it's going to be higher than that. So what's the presentation? The early presentation is antenatal. And that's why the people in the Western, because they have good antenatal care, they picked up all these cases early. When the baby born, they will just go and take care of him. But in ours, not that much. And then the late presentation, especially when the patient got home, he may come with the bilious vomiting, abdominal distension, or maybe delay in passing meconium or stool. So this is late presentation also make you suspicion. Is it a sepsis? Is it intestinal? Some other metabolic? So that will lead to late on the diagnosis. All of this can be, in some cases, I'm going to present it. This is a full-term, good Apgar score. No postpartum complication, went with the mother to the nursery, normal nursery. He started to vomit bilious. And when we did the X-ray like this. So our fellows, our junior, do we have a resident here? No more resident, no fellows. Any fellows? Neonatology fellow? شوفني تعب على الفاضي يا أبو سلطان. No fellows. Fellows, can you raise your hand? So if you show it to the fellows, when you call, this is just dilated intestine. When he sent it to me, there is a perforated bowel. I don't know where is the laser, but you can see this is a pole like, so this is a perforation. It's a mist. So this is one of the cases has been missed as intestinal perforation. And when we do the lateral decubitus, the diagnosis was there. So our junior, please wake up. Bilious vomiting is something dangerous. So we went to the OR and it was diagnosed as ileoatresia. And you know this baby, when you go back to the mother report, the baby has already been diagnosed in utero to have dilated loops. So if the people in the OB/GYN, pediatrician in the antenatal, if nobody, just go and see what is the report in the antenatal ultrasound, you may find the diagnosis in the majority of these cases. Although the false positive may be found, but that's only 15 to 30%. This is another case. 3 days old, full-term male infant, delivered normally, developed bilious vomiting immediately after birth. Baby is active, bottle feeds, it's not septic, or formula feed combination. The infant vital signs was okay, but the abdomen mildly distended, and then there was a query, could be considered to have him as a cow milk protein allergy or not. They diagnosed him as cow milk protein allergy, and they changed him to another formula. Went home. So after he has passed through different hospital with the same problem, bilious vomiting, abdominal distension, and everybody said this is just gastritis, cow milk protein allergy, change the formula from one form to another. Then he landed in our emergency with bleeding per rectum. And the baby was in shock, acute kidney injury, almost dying. Simply because the primary hospital missed it, the second one missed it, and the third one missed it. When he came to us, maybe we'll miss it if he has no bleeding per rectum. And then when we do our X-ray, it was a typical of malrotation. And malrotation with volvulus. Baby was in shock. We resuscitate, fluid. We had hard time to stabilize him until he go to OR, and the diagnosis was malrotation and has been fixed. So this is the cases of the low income. We are in high income. Wake up, our junior. Wake up. Bilious vomiting, yes, it can be normal in 20 to 30% of full-term baby, but majorities of them are surgical. Don't reassure and send him home. Call your senior, call your surgeon until you have an explanation why this baby has no bilious. So this is the bilious vomiting. I will not go to. So how we can approach them? What is the simple way? We hear from the artificial intelligence, algorithm. You need to have an algorithm. You need to have a protocol to tackle these cases. So after the baby came to you, worry for the cause of intestinal obstruction. If he's in shock, resuscitate. Start fluid replacement. Start to stabilize him from the hemodynamic as well as the respiratory. Then think about where could be the obstruction by calling somebody else, surgeon or the radiological study. Place the nasogastric tube is another step. Deflate all the stomach. Establish good IV line for IV hydration, IV antibiotics. Most of these cases, they will need IV antibiotics, at least the first 72 hours. After you stabilize him, call your surgeon to see it. And this algorithm, I get it from SBGAN. Very good algorithm. So if you have a suspicion because of the bilious vomiting, just put nasogastric tube and examine the baby anus go down. Nasogastric tube pass simply, deflate it, examine the anus. Anus is normal, there is no anorectal malformation. Then you may consider to have the diagnosis of imperforated anus or Hirschsprung disease. Then you do the plain X-ray. If the X-ray seen in the small intestine with just normal distribution, So maybe this is something lower. If you go with the specific finding, double bubble, duodenal atresia, triple bubble, something down, duodenal atresia, or for all this, you diagnose immediately that this baby has an upper problems. Bowel malrotation, you may diagnose them with this one by just looking for the bowel distribution. And sometimes, if you don't have that much of clear impression, this baby where it's upper or lower, proximal or distal obstruction, don't worry. Just admit him, stabilize him, then you can call your pediatric surgeon and start to use some other investigation like the barium. And when you do the barium, majority of these cases, you may diagnose them. So if they have an Hirschsprung disease, it will be easy by the lower GIT, send them for surgery, they will do for you the biopsy and establish the diagnosis. Simple approach like this, you will pick up majorities of this, especially the upper small intestine obstruction. Is abdominal X-ray is enough? Majority of the cases is enough. In small cases or a small number of percentage, you may need to do a barium study to rule out malrotation or lower GIT obstruction. Very common presentation, nobody will miss it when the baby comes with projectile vomiting. You don't need even to do further study or ultrasound, just call the surgeon. This is pyloric stenosis, but if you want to confirm it, you can do the ultrasound. And ultrasound, most of the time, you just look to the measurement of this pylorus. This is another case has been missed. This is the abdominal X-ray, how I can interpret it. You remember that case which is missed as perforated? Sometimes we miss even the porta hepatis, our junior. So to look for the X-ray and get the better approach, first of things, first evaluation, rule out any life-threatening condition, like perforated bowel with a pneumoperitoneum, or maybe intestinal porta hepatis, that's advanced necrotizing enterocolitis. If these two are not present, look for other classical signs. Other classical sign, easy to diagnose duodenal atresia, or nasogastric tube cannot be passed, recoil, esophageal atresia. The third thing, decide whether the bowel gas pattern is normal, is it high or low. Don't say small intestine, large intestine, say high or low. In this situation, we need to go and consult your senior, consult your pediatric surgeon. You may go to do the barium study. This is a simple approach not to miss any cases. Ultrasound, sometimes it is very helpful, especially nowadays with the focus and point of care ultrasound. We start to use ultrasound and diagnose neck only with ultrasound, Professor Joseph. We don't need to have the X-ray. And sometimes we may miss pneumoperitoneum, pneumatosis intestinalis by the plain X-ray, but we pick it up by ultrasound. In 2 cases, we have them recently. So sometimes the X-ray and ultrasound may add to you another tool to diagnose necrotizing enterocolitis. Do we need further? As I told you, we don't need further, but sometimes you need to have small or upper GIT study to rule out any malrotation or large intestinal obstruction. This is, we saw it. This one is very common. Joseph Billy showed to us. And this is what? Baby abdomen distended. He has the abdomen like this. But when you look, there is nothing life-threatening. No pneumatosis peritonialis, no porta hepatis, no free gases. So if you look at the baby in CPAP. And the CPAP belly to feed or not to feed, Joseph, he explained to us. But very interesting thing that we say, it is common in our unit. I found this. So when you have CPAP belly and the abdomen is like this, baby cannot tolerate the feeding. In the majority of these cases, there is something called, this one has been seen in the literature to reduce that CPAP belly, has been published in Neonatology Journal 2024. Actually, it is an anecdotal report for cases that they respond very well to this pill when they have just CPAP belly. Make sure it is CPAP belly. It is not a necrotizing enterocolitis. It is not perforated before you put that belly. I was trying to find it in our market, not yet. Do you have it, Joseph, in North America? We don't have it. So still maybe just a trial for this bill. And this is the report, neonatal abdominal support to decrease the CPAP belly in abdominal distension, but again, make sure it is not surgical, it is not neck, it is not pneumatosis intestinalis, it is not a pneumoperitoneum. Then you apply CPAP. I'm afraid that you'll apply CPAP and the baby is perforated spontaneously or neck. This is the baby who was suspected antenatally. And as I told you, that the high-income country, North American, and Saudi Arabia also, majority of the cases, we picked up them early by the antenatal ultrasound. But the problem, we don't follow this antenatal ultrasound. Majority of the baby, they born, even we don't know what is their finding, there's no communication between us and the OB-GYN to know this baby has some dilated bowels, has double bowel, we send him home. He will come to the emergency with the same scenario, and this is one of the reasons we have high mortality in the low and mid-income countries. But majority of this, you can diagnose them antenatally by just double bubble or dilated bowel loops. Junior, 500 riyal from Dr. Gattan if you answer. Halas Gattan, you give? 500, he's the, what's your diagnosis? أنا سألت خلاص هتعطي فرصة. Oh, في chat GPT. They will picture it, they put it in chat GPT and get the answer. This is artificial intelligence. Easy. Triple bubble genotype, 500 from Dr. Gattan. Catch him. This is unusual bilious vomiting. This is the baby who was almost 2 days, born normally, good Apgar score, was very irritable, crying very badly. And then when you do this, we found this. He came from the emergency, actually, after he went home. What is this? Very bizarre lobes dilatation. And it was not obvious with this one. Do you have an idea what this could be the diagnosis? Hirschsprung? Maybe because the anorectal, there is a gas. So when you find a gas in the anorectal area, unlikely to be Hirschsprung, but only the dilatation in the proximal. So we call our pediatric surgeon, please come. Bilious vomiting in this bizarre looking, and he came, and actually he do the ultrasound, and he found these loops. So what's your diagnosis now? Intussusception. So neonatal intussusception has been reported in literature, and this is one of them. And when they take him to the OR, they found this bowel has eating each other. So ilio-ileal intussusception. So that's a very common. This is his pictures on surgery. This was from Aramco, John Hopkins, high-income country. Aramco is in our, in Sharqiya. I'll go this one. So this is neonatal intussusception. And finally, we have this case, 28 weeks baby, recovered from Hallam membrane disease, blood culture stained stool, so bloody stool. But the baby was okay. No apnea, no bradycardia, hemodynamically stable. So when you had like this, usual diagnosis, maybe neck. Everybody will say this is maybe neck. And actually, when we x-ray him, he has pictures of neck. Pneumatosis intestines everywhere. So we kept him in PO for 7 days. We treat him with antibiotics. After he finished his course, stabilized, no more bleeding per rectum, we refeed him again. The same symptoms. He started up bloody, diarrhea, bloody stool, little bit of abdominal distension, but the baby is fine. So we keep him in PO again. And when we do X-ray also the same, pneumatosis intestinalis. What is this? Could be recurrent pneumatosis intestinalis. Could be mesenteric blood flow, abnormality in the mesenteric blood flow. We put all these possibilities. What else could be? ارفع صوتك عشان 1000 ريال عبد الحكيم قطن بيعطيكي. ارفع صوتك يا بنتي. خلاص عبد الحكيم 1000 ريال. نتوقعش our fellows عشان يحضروا معنا كثير. So we put the possibility this baby maybe he has some intolerance or what we call it enterocolitis from the protein, cow milk protein allergy. And cow milk protein allergy can mimic our necrotizing enterocolitis. Yes, you can have recurrent necrotizing enterocolitis, 1 or 2, but not 3. But when you have a recurrent necrotizing enterocolitis, think about cow milk protein allergy if the baby on formula or he is getting HMF. Actually, this baby was getting HMF breast milk. So it is from the HMF, which contain cow milk proteins. high proteins. So cow milk protein allergy. If this is not a cow milk protein allergy, you need to look for the mesenteric blood flow. Do you still have time, Mr. Chairman? You are enjoying? We'll have to stop because Salah. So this is cow milk protein intolerance. You know what? The terminology is just simple cow milk protein allergy intolerance, or maybe an inflammatory marker, an inflammatory of the bowel, skin inflammation, give a picture like a volvulus, or give a lecture like necrotizing enterocolitis with a lot of the inflamed bowel. Simply just hold the protein and label him as cow milk protein allergy. Let him go to the formula, which is the hydrolyzed formula, or breast milk. Or breast milk sometimes may comes as a cross if the mother is getting daily product. So this is the last. In conclusion, it is challenging for us, especially in very high income, with the outcome of the low income. That's what burned my heart. So we are in high income, but still, this after yesterday, I hear from one of my colleagues, somewhere here in Riyadh, they have no pediatric surgeon. They have to transfer the baby from Kharj to military here because they have no surgeon. So access, easy access, is more common getting missed, and missing cases lead to high mortality. So we need to have a good clinical approach, good algorithm, good suspicion, early intervention. With that intervention, you may have the best outcomes. And that will conclude my talk. Thanks a lot. Shukran.
Thank you all for the beautiful presentation, and I don't think anybody is sleeping after you, Abdurrahman. And mashallah. And that was not CPAP Billy. There, the baby was intubated. I saw the AT tube. Correct your X-ray. I have a question specifically for Professor Neo. I'm interested in the AI for some time now, and taking some courses as well. I've been speaking about that, and I've been advocate for it. And Jubar, I don't know if she's still here. We're like, we want to see it, and we have some discussion. Now, as you can see, people are worried to use it. Now, actually, my worry that people are not using it. Why? Because if you look at the diagnosis or the prediction, we are seeing now more and more evidence that the prediction and diagnosis is more accurate using the AI because of multiple things we are using to reach a diagnosis, right? Now, I came across a study when I was preparing one of my talks, which was published just in March in Nature Medicine from Stanford University about the use of TPN using the model. And they trained just to let everybody knows what I'm talking about, they trained the AI on 80,000 prescription, and then they verify it for in another hospital over 80,000 prescription. And what scares me now here, that if we deviate from the recommendation from the AI, the mortality and necrotizing and cholestasis and other complications will increase. Now, is that going to put the people who are not going to use a validated AI model at risk of medical legal litigation or no? That's what we should worry about, not to use it. I mean, whether we use it or not, we should worry about if we don't use it, what will be the sequelae, what will be the consequences. I would like to hear your wisdom.
I think that we are in a phase of AI similar to what we were in the early 1900s with airplanes and cars, and people who just saw airplanes and cars, they would look at them and say, oh my gosh, people are going to be falling out of the sky, they're going to be dying. Well, certainly it has happened, but it's extremely rare. And certainly there are problems with driving cars. But I think that that has helped us tremendously with augmenting our mobility to be able to get around. So I think that this is still in the phase that we are. It has its certain limitations, obviously, but we have to use our human judgment, and I think that that's really important, to continue to use our judgment. And I don't think that AI, at least not in the very near future, is going to replace any of our human judgments. So it's interesting that you bring up the Stanford paper. I worked very closely with the group that published that paper. And what they did was, and I didn't talk about it in my lecture, but they did clustering using different TPN requirements. And they have 15 different TPNs for babies now. But the problem is that they never even took enteral nutrition into account with this. So in reality, I don't think that that is going to have as strong of a clinical implication directly, but it does show that you can cluster these babies into different requirements for TPN. So it's very valuable in one way, but taking it to the actual neonatal intensive care setting where we are now enterally feeding most of these babies anyway, I think that too, it's not going to be very practical.
Thank you very much for all speakers. Excellent talk, everyone. I just have a couple of questions for Dr. Nu and a question for Dr. Ibrahim. So I'm a bit confused about probiotics. The FDA issued a warning, and everybody got scared after that. And then we got from the CNN data that it actually shows reduction in sepsis and everything. So I'm wondering, as expert opinion, what should we do at this point? Where are we going? That's number one. Number two, about the SIFT trial. So they were comparing 20 or 18 ml versus 30 ml. Would we go that fast in a country where we still rely mostly on formula? Is that a rate limiting step? Is that something that should make us worry and go a little bit slower? And also something interesting, when I speak to colleagues about the SIFT trial, we get a lot of pushback looking at the secondary outcomes. The neurodevelopmental outcomes were actually worse in babies that had higher or faster feeds. I can't find an explanation in the paper, so I would like to hear about it from you. For Dr. Ibrahim, my question is about not donor breast milk, but we had the situation, and I don't know honestly if there is a policy somewhere in Saudi Arabia. If we get a mother from a relative or somebody like a wet nurse, are we able to use it? Is there any precautions about using it? Is there a pathway around this, or should we just lie to everyone and say, as long as you tell me it's mom, it's mom? What should we do? Thank you.
So, you want me to start? Okay, you had two questions. The first one was about probiotics, and the other one was the SIFT trial. So, the whole issue of probiotics is very interesting, and in 2010, a meta-analysis came out by Deshpande and colleagues, which I think really changed a lot of the emphasis and use of probiotics. This was a meta-analysis with 10 different probiotics done in 11 different neonatal intensive care units. And along with that meta-analysis, which looked very favorable for probiotics, there was a commentary that said it is now unethical not to use probiotics. There was a commentary telling us that we...
From company or from?
No.
Not from the company.
No, not from a company. This was from a well-established, I'm not going to mention the name, but a neonatologist. And so I think that when you have that kind of a commentary on a paper, then whole countries started changing their practice. Canada, Australia, Japan, many countries, whole countries started to use probiotics routinely. And there was a meta-analysis that seemed to come out every year with more and more of these trials. But one thing to remember is in that meta-analysis, there were 10 different probiotics. Which one do you use? One of those probiotics, if you look closely at the secondary analyses, showed, this was the one from Taiwan, showed 4 times as many deaths, or many more deaths in the probiotic group than in the non-probiotic group. But that was never even mentioned in the meta-analysis. So I think that which probiotic do you use? What dose do you use? And these are foods. These are not made by standards, drug standards. And when you look at the actual studies that were adequately powered for necrotizing enterocolitis, one that comes close was the ProPrem study that was done in Australia, but necrotizing enterocolitis was not the primary outcome. Sepsis was the primary outcome, no difference. Slight increase in, slight improvement in the secondary outcome in neck. Then another trial was done with 1,400 babies in the UK. No difference in sepsis, no difference in neck. It was powered for necrotizing enterocolitis. Another trial, the one that I was most recently involved in, and this is not yet published, the Connection study, 2,200 babies, 95 different neonatal intensive care units using Lactobacillus reuteri, and very, very well done prospective randomized trial. P-value with necrotizing enterocolitis was 0.247. 0.247, not significant. But then, when you looked at mortality as a secondary outcome, there was a difference in mortality favoring the agent, and we're not calling it a probiotic, and I'll tell you why shortly. We're calling it a biotherapeutic agent, okay, not a probiotic. The mortality was different, and then when you actually looked at gut necrosis seen at surgery, that was also different. And if you looked at what was diagnosed as neck after 14 days, there was also a trend toward being different. But those are all secondary outcomes, and that is something that makes this kind of a paper kind of difficult to publish if you are going to try to emphasize secondary outcomes. So this is problematic. Now, why are we not calling this a probiotic? Because this company actually went to the Food and Drug Administration in the US and also went to the European agency and got permission to do the study. And so they went through the process of putting this together as a drug. So they did the secondary analysis outcome for safety, then they did the efficacy analysis. And after 2,200 babies, there's no difference in the primary outcome. But one of the reasons I don't think that there was a difference is because what I was talking about before. About 85% of the babies were diagnosed as having neck by radiologic criteria. And radiologic criteria stink, okay? They're not very good measures. And I think that whenever any kind of a future trial that is going to use radiologic criteria is going to be potentially flawed. And this is one of the problems that we have with studies with neck. So I'll stop there with the neck question and then go on to the SIFT trial. Go on to the SIFT trial. And with the SIFT trial, very quickly, those were secondary outcomes. And I think that what they do is raise a flag. Okay, they raise a yellow flag saying, okay, we need to look at this, but I would not completely negate the primary outcomes of the SIFT study because of those secondary outcomes. I think the SIFT study tells us that it is possible in many of our babies to advance them more rapidly, but we still have to be somewhat careful in doing that. And this is why I bring up, the other ends of the Gaussian distribution, that there are some babies we can go much faster than 30 milliliters per kilo, and there are some babies that we really have to go slow with.
Thank you, Dr. Talal. Regarding the breast milk, I'm not aware of national clear guidelines to be has been established. There are different guidelines from different hospitals. Probably Dr. Jbara knows more about it. If I understand your other question is that if they bring breast milk from a relative, whether we give it or not. Again, there is no clear or no definite guidelines have been established in that, but at least it has to be, the mother is screened for CMV supposedly, so before giving it, I think we have to screen it for viruses. Okay.
Talal, recently in the university we received a very big project يسمونه حليمة السعدية للإرضاع الطبيعي. وهذا has been established in Malaysia. اللي هم a mother, she bring her sister, her relative to feed her baby preterm, has been established في ماليزيا في الكويت. احنا we are almost adopting the same policy. We're still under rewriting it, readjusting it, getting the legal part of it, and الشرع منه حكمه. They have approved it. I hear from Professor Mouzan recently البارح. They have approved it من الشرع إن إذا كان المرأة she knows that donation mother or donating milk mothers who signs already, they agree about the two families حتكون أمها من الرضاعة. It's going to establish soon إن شاء الله. حليمة السعدية موجود في النت. Just go السعدية للإرضاع الطبيعي.
طيب, thank you everyone for this interesting topic, specifically regarding the donor milk. I see that Professor Neo mentioned about the pasteurized donor milk. And I understand the importance of pasteurization process in order to eliminate the CMV and other infections and so on. So it's well established that pasteurization process is eliminating many factors, beneficial factors from immune and macronutrients from the milk. If we came up with the screening of maternal or the donors of mothers, especially we are not going to adapt a complete donor milk processes from the Western country as we have some religious and legal restriction regarding the donor milk. So that's the screening process for such CMV and so on, eliminate the pasteurization process and hence given the benefit of actual breastfeeding, even if not its own mother milk.
So that's a very interesting concept, and I think that if the donors are closely associated with the baby, you may even have a little bit of this enteromammary response that I showed, and especially if the donor spends some time taking care of the baby. You know, I think that there could be that positive effect. In Brazil, this is a very interesting thing, that one of the things that they have been doing is for premature babies, they have been routinely pasteurizing baby's own mother's milk based on one study showing high levels of CMV antibodies in that milk, but is it actually a CMV that could affect those babies? And we are in the process of working right now. I've got a couple of infectious disease experts and folks from the US and in Brazil looking at this very closely, and we want to write a review on that. My own personal bias at this point is that it is totally and probably not a good idea to pasteurize the baby's own mother's milk. So I think that to not pasteurize the individual donors that you're talking about here is probably not necessary. But again, that's my bias. I don't have a lot of good evidence behind that.
Thank you. Just, to make you aware that the Association for Breastfeeding Committee, which is, well recognized, society, they have a project also, maybe similar to this Halima Saadiya or whatever, but they have some people who can participate by donating the breast milk. And they were happy to organize and to help for those mother to donate milk for certain babies. And then I think if there is some regulation to help the society, I think it will be a very good solution rather than breast milk banking or anything like that. But we use the allowed, and it should be lawful, but just to put some regulation for it.
I think also should be governance for this issue, I think should be registered in NAJS also for the future. اتفضل.
Thank you very much. So for breastfeeding in our center, more than 10 years, we do a donor milk, but it's the parent who's the one who bringing the milk, screening for CMV and screening for HIV, and documented. Nowadays, it is mandatory to register through our national tunnels, which is the ABSHIR. So they call توثيق الرضاعة. So anybody breastfeed another one, they need to go through our official channel, and it was documented in the IDs and officially. So they know who's the mother who donated her milk. My question to Professor New, simple question, when we can have a definition, a true definition of NIC, because it takes very long time to have a definition of necrotizing enterocolitis. The definition we use, the radiological and the clinical, it's both stages, it's like since 1970s. And so can we have a consensus nowadays about how we can define necrotizing enterocolitis?
So I have been asked to be on a Delphi panel to do exactly that. And my comment to them was, no, we're not going to be able to get a definition of necrotizing enterocolitis. We need to go back to the 1970s, make believe we're in the 1970s, use our new techniques that we have available now, and totally redefine or recluster different intestinal injuries, and we will have different names for those clusters rather than necrotizing enterocolitis. It's sort of like autism. We're calling autism, one thing. There's many, many different forms of autism. Diabetes, we still call it diabetes, but it can be very confusing because the different forms of diabetes, there's like 5 of them, all have different pathophysiologies. And so when somebody says, I've got diabetes, you don't know what diabetes they have. So I think that this is actually counterproductive to have a name like autism, like diabetes, like necrotizing enterocolitis, and make believe it's all the same thing. It's not. We need to have a different paradigm. And so definition, I think I would personally like to see us getting away from it. It's not going to be easy.
Last comment or last question?
Have one question. So nutritionally, we're having a huge debate in our unit whilst we're making our small baby protocol with regards to weighing babies, the extreme micropremies, because nutritionally, a wrong weight can have significant nutritional implications. You lose the first 7 days, and you might never catch up with that nutrition for months. But that balances against the risk of handling, weighing, risk of IVH. And I'm just curious, what's your practice? At the moment, the recommendation coming from our nutrition group is that we weigh these babies every day for the first 10 days, which is something that I'm going to really struggle with, considering I'm a heavy advocate of don't touch them. So I'm just curious what your practice is and what consensus is followed.
Unfortunately, our practice is just like yours, to weigh them every day. But your point is well taken. I think that especially in those first 10 days in those babies, they are going to change their weight. And usually we don't do much based on weight anyway. We certainly don't change their nutrition based on weight. If anything, we may alter their fluid balance or do something differently with their fluids. But do we do anything nutritionally that's different? No. So your point is well taken. I don't think it's very useful.
Even with the fluids, we've got so many other parameters, the serum sodium, the ability to look at input and calculate insensible loss. The bigger problem that I face with that is you're weighing a baby before all the apparatus sits on it, and then suddenly it's got tubes, lines, everything, and an incubator scale that has a standard error of about 100 grams. So,
this is a dogma that needs to be addressed, isn't it? I agree with you.
Thank you so much for all speakers. Thank you for all of you to attend to the last of the day. We will conclude our sessions today. Thank you so much.
Thank you very much all for staying so late now. I think this is an appropriate time for all of us to take a group picture, maybe. Dr. Ibrahim and Professor Neo and also Sharma, can you kindly just come into the stage, and everybody who would like to join us in the picture, please feel free.